Our third presentation will be by Dr. Traci Kurtzer and Dr. Rajal Patel. Dr. Kurtzer and Dr. Patel are both clinicians in the obstetrics and gynecology division. They will be talking about sexual health after gynecologic oncology. Thank you both for joining us.
Yeah, thank you so much. Can you hear me okay?
Yep, absolutely.
Great. Okay, and the screen's up. Yeah, so thank you so much for the invitation to be here with you all today, and definitely for the opportunity to share the work that Dr. Patel and I do every day at the Center for Sexual Medicine and Menopause at Northwestern, which is under the directorship of Dr. Lauren Stryker. So one of our many roles there is to support the patients that are being seen by our oncology colleagues. And we help primarily with some of the sexual health and hormonal health issues that arise due to their cancer diagnoses. Now, as you can imagine, sexual health is usually not the first thought that comes to mind when we're given a cancer diagnosis. And that, of course, would be expected, but sometimes worries do start very early. And so we're also available certainly for consultation about what to expect, what might be some issues that come up even before treatment has begun. But however, usually, if I can get my slides to advance here. For some reason, it is not advancing. Okay, did that one advance for you all? So great. So usually we are seeing patients, though, kind of in what I consider different stages of their cancer care. So certainly immediately right after diagnosis, within the initial months, there can be some more short-term issues that come up in the months to year that follow, and then longer-term issues as a result of some more permanent anatomic changes. So I'm going to go over a few of these first. In the immediate term, certainly just the physical effects, right, from the treatment, surgery, radiation, chemotherapy, and oftentimes as part of our care, particularly surgical care, recommendations are given for what's often referred to as pelvic rest, which is really means specifically sexual rest, meaning no penetrative intercourse, but other sexual activity often is not off limits during that time. So these are, things that can be spoken about in consultation with us. There's often just post-operative pain that can involve the pelvic area that just limits normal sexual activity. And then, of course, some of the sequelae from surgery, from chemo radiation that leads to fatigue, just kind of generally not feeling well or malaise, and then side effects maybe that come up from some of the medications and treatments that are prescribed. But also really significantly is just kind of the psychosocial aspect of that immediate cancer diagnosis and treatment. I mean, certainly there's that immediate focus on treatment and recovery and a lot of doctor's appointments and kind of intentional work around survivorship immediately. And so oftentimes there just really isn't the time or energy or mental capacity to even consider sexual activity. And that's, sometimes conversations that we have to have with our partners. And there can also be actual kind of fear and avoidance of our partners just because there's concerns that if there's intimacy in some way that it might lead to more advanced sexual activity that could be harmful in some way. And so having those conversations can be very helpful up front. And then just the general, anxiety that surrounds a cancer diagnosis and even depression, which can certainly have a very direct impact on, libido and our sexual health as well. And in the short term, we start to see more of the effects of like hormonal changes and some of the physical changes that might happen as a result of our either diagnosis or treatment. Particularly, so many aspects of gynecologic cancer care lead to deficiencies potentially in some of our hormones like estradiol, progesterone, or testosterone. We know that, certainly surgical treatment of uterine and ovarian cancer involves removal of the ovaries. Many of the chemotherapies can lead to basically induced, premature ovarian insufficiency. So those hormones aren't being produced. And then some women are choosing, of course, to do prophylactic ovarian and tubal removal because of having genetic mutations like the BRCA mutation, chemotherapies that are given, not necessarily for gynecologic cancers, but breast cancer, and some of the medications used in treating breast cancer also can very much affect our hormonal makeup. And so the impact of that and how it relates to sexual health, well, when our female hormones are low, certainly vasomotor symptoms like hot flashes and night sweats can kick in. And those on their own or even just independently, we can have quite a bit of disrupted sleep, which can lead to low energy. And those hormones are also really critically important. They're kind of the building blocks for the brain centers that drive our sexual response, or kind of the libido centers in the brain as well. So you can see how having those deficiencies really can directly impact. And then there can be some other, effects on our body. There's metabolic changes that often accompany menopause in general, and that certainly happens even in the context of surgical or chemotherapy-induced menopause as well. Weight gain can result, and that can affect somebody's, self-esteem and how they're feeling about themselves as a sexual being. And then the direct impact of those hormones on our physiologic responses. So arousal response, engorgement, lubrication, orgasm are all very intimately tied to our hormone levels. And then there can actually be some impacts also in tissue health for the vulvar and vaginal tissues that can lead to dryness. It can lead to atrophy, which is basically thinning of the tissues, or dyspareunia, which is pain with intercourse. And I'll cover those in a little more detail. But you can hopefully get a picture of how all of these can so primarily very strongly impact libido for individuals who are dealing with cancer diagnoses, but particularly gynecologic cancer diagnoses. So we talked about hormonal health and the impacts, and certainly we know that surgically induced low testosterone levels can impact libido quite directly. We talked a little bit about the body image, it was mentioned earlier too, how that impactful that can be, hair loss, weight gain, all of those changes that might accompany the treatments. The low energy, again, possibly secondary to some of the hormonal effects, as I mentioned, also radiation, chemotherapy, post-surgery recovery. And then painful sex in itself really is just such a negative feedback loop to the brain. So those drive centers are definitely going to be inhibited when there is pain involved. So that is something we really focus a lot on treatment in our center. We want to regain or at least block any negative feedback loops going to the drive centers. And then if there is diminished orgasm, we're kind of missing out on a little bit of that positive feedback loop to the drive centers to want to engage again in the future. So those are also conditions that we treat as well. And a little more detail about what can cause painful penetrative intercourse. Primarily, we see genitourinary syndrome of menopause. Again, this is can happen with natural menopause, but definitely is a result also of surgical or chemotherapy-induced menopause. And what this refers to is basically the thinning of the vaginal and vulvar mucosal surfaces, and that can lead to little micro abrasions, tiny tears or lacerations, which we call fissures, and then that also can lead to decreased lubrication, which can cause some dryness and friction. That can even happen, not only with penetrative intercourse, but sometimes even just with physical touch on the external vulvar tissues. These changes also can lead to some and impact the lower urinary tract and lead to some bladder types of symptoms like frequent or urgency in voiding or irritated voiding, and also increased risk for urinary tract infections. The clitoris can be involved as well with atrophy, which can contribute to decreased orgasm. And again, kind of feedback loop for that low reinforcement to our drive centers. In addition, sometimes as a result of surgery or radiation, there can be physical changes to the vaginal canal with stenosis, which is basically a narrowing of the vagina, or shortening, so there's not as much length. And of course, that can lead to pain for individuals dealing with those conditions. And then pelvic floor muscle tension is also something we really commonly see, which is issues related to, pain, recovery, pain from the surgical healing, any, issues related to this genitourinary syndrome of menopause, as I refer to, can lead to reflex contraction in the pelvic floor muscles, and that can then become a secondary source of pain. So some of the things that we can offer for treatment for the dryness or genitourinary syndrome of menopause, or what we formerly called vulvovaginal atrophy, there are different treatment options. There are vulval and vaginal moisturizers, which are basically like what I consider like lotions for the vagina. Those are non-hormonal options. There are some hormonal options like vaginal estradiol, which can be in ring, tablet or suppository or cream formulations. There's vaginal DHEA, which is a precursor hormone. It metabolizes into estradiol and testosterone, but it's formulated as a DHEA suppository. There's an oral medication that's SERM, or selective estrogen receptor modifier, and that is kind of, I think many of us have heard of the drug tamoxifen used to treat breast cancer, and basically the one that we use is a cousin of that that's really directive towards vaginal atrophy. And then there's also laser therapies available, which are not at this point generally approved by insurance companies for coverage, but sometimes there are some workarounds for that as well. For the condition of shortening or stenosis, vaginal dilators are available and can be purchased, and instruction can be given. So kind of counteracting some of those physical changes that we spoke about. And then pelvic floor issues can be addressed very well, very successfully by pelvic floor physical therapy. And pelvic floor physical therapists do additional training to work specifically on those muscles. And we have 3 exceptional PTs that work out of our office directly to help individuals who are dealing with this condition. And then specifically, for treatment of low libido, as far as those hormonal effects, what can we do to maybe help improve sleep, energy, maybe mollify a little bit of the weight gain issue? For those who there's no contraindications, we can offer systemic estradiol therapy. Another FDA-approved option is using drugs from our antidepressant class of medications, or the SSRIs. And then there's also some similar antidepressants that seem to work well for helping specifically with vasomotor symptoms. Testosterone can be used. It's an off-label use. It is not FDA approved, but in those who have demonstrated testosterone deficiency and again don't have any contraindications to use, that can be offered. Interestingly, a medication called gabapentin, which is often used for pain management, can be really a helpful medication for sleep and pain. Also appears to help with hot flashes and night sweats, so can improve those symptoms and quality of life overall. And stellate ganglion block, which is a also not FDA approved procedure, but is undergoing studies right now and seems promising to help with these symptoms. For acupuncture, there's certainly very limited data out there, but there has been some anecdotal evidence that that's an option that can help individuals as well. And then I loved the discussion that Dr. Pont had this morning already about the use of CBD or marijuana. Interestingly, that is also an option to consider for treatment of vasomotor symptoms. In fact, in one study, about a little over 1 in 4 women had used those products to help with their symptoms, but really no controlled trials for sure, very limited data. But again, shows some promise as once again another use for CBD or marijuana. And to treat the painful intercourse, I just went over many of the options there. To specifically treat kind of a lowered drive center, we can offer sex therapy, which is really very directive cognitive behavioral therapy to really try to kind of kickstart those drive centers again. For any individuals who may be also having any kind of relationship issues as a result, psychotherapy or couples counseling can be helpful for those who maybe have a history of coming from some type of sexual or medical trauma in the past. Trauma therapy can be quite helpful. And then there are some medications available that are not available to everybody, but things that we can talk about to again help with the drive directly. And so at this point, the last kind of conversation was about some of the long-term effects. These are the sequelae that happen because there's actual surgical changes that occur to the body from various cancers. And those can be, direct cancers of the vulvar tissue, vaginal areas, cervix. Dr. Patel was going to come on at this point. And
yeah.
A couple
Can you hear me?
So if she's on, I will let her take over.
Great. So I just wanted to go through some specific cases to show how we can help the sequelae of the surgery and how we can enhance sexual function afterwards. So one case is one of my patients who had a high-grade squamous epithelial lesion of the vulva. So this isn't a cancer, but it is a precancer. It treated with surgery, and sometimes the surgery can be quite radical, where a lot of tissue has to be removed. Sometimes that can narrow the vaginal opening significantly. It can also, because of having to put whatever's left back together, it can also reduce the elasticity of the vulva. And a lot of people can have pain in their scar tissue area. So one thing that we can do before I do these surgeries, I plan out with the patient, draw on their, with a marker, with a skin marker, show them what to expect and how much tissue will be taken off. And if we anticipate a lot of tissue being taken off, then sometimes we'll get the plastic surgeons involved so that tissue from elsewhere in the body can be used to graft onto where the tissue's been taken so that some of that elasticity can be preserved. So that is for the vulva. And the next patient that I had an adenocarcinoma of the cervix. However, she was in her 30s and she wanted to leave the option for carrying a pregnancy. So she underwent something called a trachelectomy, which is removal of just her cervix. And in order to close what's left and still maintain that uterus, the surgeons had to put in something called the cerclage. And that's basically a stitch, material that's put in to tie off that area. Unfortunately, while she still has maintained her ability to carry a child, she ended up with a lot of abnormal discharge just from the foreign body being in that area. And that abnormal discharge she was changing her pads 6-7 times a day, and it became debilitating to the point where she wasn't really able to have sex, and her body image was significantly impacted. So we went out of the box and thought about how could we help her with this discharge. And we ended up using anti-inflammatory medication inside the vagina, still safe to use in pregnancy if she were to conceive. And while she still has this discharge, she has been able to regain control of her sex life. And then another patient had radiation changes she had childhood cancer, and the radiation left her vagina with decreased elasticity and a lot of scarring. So she actually did really well with the dilators that Dr. Kurtzer was showing, and then with some formal physical therapy. And there's also estrogen we can use in that area, and anti-inflammatory medication such as steroids inside the vagina to help release some of the scar tissue. And one more thing I wanted to address is that sometimes we have patients who are getting their ovaries removed, not because they have cancer, but they are at high risk for developing cancer. And some of these patients may be candidates for hormone therapy, systemic hormone therapy. So giving that estrogen back to them when their ovaries are out, so they don't have early menopause. And that has to be a case-by-case basis. So we're happy to see those patients before they undergo their surgery to make a plan with them and also work with their oncologic team.
Absolutely. And this is our contact information. We hope that this just has changed a little bit of the view. I know there's a lot of scary things that come up with a cancer diagnosis. Sexual health and hormone health is one of them. Hopefully we gave you some ideas there, and we're on the 24th floor at the Lavin building if you need us or if you want to refer any family members. Thank you so much.